My name is Jen Muller. I am the physician liaison for Seattle Children's in the north. Patty, you can do a quick wave. If you speak, you'll be highlighted.
Down Bellevue South.
And then Kenton. While we're finding Kenton, just want to say welcome all of you guys and thank you for taking time out of your busy day to attend our first virtual CME. Really exciting. We have over 80 attendees for tonight's talk. We reach all the way down to the Olympias, up to Bellingham, and all the way over to Coeur d'Alene, Idaho. So kind of neat to know that we have all these pediatric providers listening on a topic by three amazing Seattle Children's neurology providers. As mentioned, today we're going to start it off with Dr. Wainwright's going to just give a quick little overview of what's going on in the neurology department today, post-COVID. And then Dr. Blume is going to be talking about headache. And then we're going to move on to Dr. Novotny, and he's going to be speaking about first-time seizures. Please feel free to use the right-hand side, the chat box, to ask any questions. We will be monitoring those, and we'll try to do them in a very timely fashion, almost every slide. At the end, we also have two special guests. We have Aaron Williams and Dave Stolte online, and they're here just to answer any questions and also to give you some insight as to what's going on in our regional clinics, again, as we get back to normal business. With that, I'm going to go ahead and pass it over. Kenta, if you want to say a quick hello, if we can see you, and if not, we'll catch you at the end.
Good evening, everybody. My name is Mark Wainwright. I'm the division head for Child Neurology. I'll keep my remarks quite brief since the focus tonight is on the headache management and evaluation from Dr. Blume and first-time seizure evaluation from Dr. Novotny. The division has a number of subspecialty programs in addition to epilepsy and headache that are listed here. I think also of particular relevance for your practices is that for the past 16 months or so, we have instituted an acute access clinic in which we are committed to see patients within 2 to 5 days of referral. We have some triaging processes in place to determine which patients meet those criteria, but we continue to offer that service and see those patients in person throughout the COVID-19 pandemic. Our practice has switched over, as I expect yours have too, initially to an entirely telemedicine practice, mostly by phone, now televideo, and we're finding an equilibrium again with seeing patients in person. We're switching back again to seeing more patients in person as we adjust our practice to what we believe patients can be seen safely for new evaluations. But the message for you really is that the division remains open. We are seeing new patient evaluations for headache, epilepsy, other disorders in a combination of in-person visits, which we've continued throughout this, as well as remote visits. We're glad to take questions about our processes if that's helpful to at the end of this talk. With that, I'm going to turn this over to Dr. Blume, I think, who is the first speaker. Thank you.
Great. All right, so obviously talking about headaches in 20 minutes is a little challenging. There's whole meetings and week-long things developed to this. So this is just going to be an overview. And I'm just going to see if I can look at the chat. Just let me know if you can't hear me. Somebody can unmute themselves or if there's any problems, because there may be some background noise occasionally. So I'm just going to go through some of the very basic things and review sort of what is helpful for us when people providers send us patients to see in the headache program, and also review what the headache program is like. So a few quick things. I think a lot of times I get asked sort of when should we do imaging? It's really hard to do imaging. It's easier to get neurology visits than MRIs sometimes. And then it's really, there's a lot going on in migraine right now. There's more therapies that have come out for adults, at least in the last 2 years, and are pretty much in the history of migraines. In addition, the AAP, AAN, and Child Neurology Society published guidelines about acute updated guidelines about acute treatment and prevention of migraines just last year, which has been well overdue. And then the slides, I'm just going to review some of the resources we have for children that are accessible to providers everywhere, or even families at other places, and some other online resources. So I'm trying to figure out who needs imaging, when do you have to worry about a secondary headache or brain tumor, because pretty much most families are worried about a brain tumor, especially if they have a younger kid with headaches. It's really, most of it is in the history, which has made transitioning now from the telemedicine perhaps a little bit easier for us than for some other specialties. And then the exam is also important. And then figuring out from those, the first steps, what testing is needed, if testing is needed, and what the next steps would be. So Joe Pinter used to be, started off his career here. He's now down at OHSU, but he was involved in the publication of this article, which I like. And this is one of the areas in neurology where we actually do have a lot of information about when we need to do imaging and when we need to worry about that threaded brain tumor or space occupying lesion. So this study, Medina et al., looked at sleep-related headache and found that these things were, some things were associated with basically a neurosurgical lesion or space occupying lesion. And the more of these things you had that were present, the more likely you were to have a problem, a neurosurgical problem. So sleep-related headache, meaning headaches waking kids from sleep, headaches only in the morning. Things that were kind of protective were family history of migraine and aura. So if you had actually had a visual aura, that was much less likely to be a structural problem than migraine. Confusion, short-lasting characteristic headache, and abnormal exam were all associated with a higher risk of having a lesion. So that's why those things, if you have those issues come up in history, you do want to consider imaging. Other things that are worrisome that weren't particularly brought out in that study, but have been looked at in other things, and kind of focal headaches, change in headache types. I think suddenly had one headache a week, one headache a month, and then suddenly have daily headaches that are severe. Those are kids you want to consider imaging in. If the headaches continue to get worse and worse and worse over time, or if you have headaches with Valsalva, the whole question about occipital headache is now a little less clear. Most kids with occipital headache still don't have a surgical or a lesion, a structural lesion, as some of the folks have looked at kids several hundred kids who had MRIs with occipital headache, and very, very few of them actually had any lesions without some of the other signs. So this is an incomplete list of secondary headaches or other things besides, in addition to structural lesions that can cause headaches, obviously tumors, vascular abnormalities, bleeding, hemorrhage, infection, sinusitis, even dental infections. So if you've got a lot of dental issues, that could certainly be triggering headaches. Fever, meningitis, encephalitis are obvious. Trauma, post-traumatic headaches. If the kiddo has lupus or some other disorder that puts them at risk for headaches, you want to consider imaging for the workup. If ideally want to get a good ophthalmological exam, get an idea if they have elevated ICP. Low ICP is possible, but also less common in kids. I do screen for thyroid if kids also have lethargy or fatigue, which is not uncommon. I also will sometimes check ferritin, make sure that they're not iron deficient or anemic. Obviously, medications, drugs, toxins, ADHD meds, doxycycline, minocycline can all cause headaches. Reviewing that's important. I still remember one of the kids I saw with pseudotumor or idiopathic intracranial hypertension. She hadn't mentioned the fact that she was taking doxycycline because that was her skin doctor who gave it to her, and so I think I was the fourth person she'd seen, and nobody else who's talked to her had realized that she was on doxycycline. And then pregnancy and other issues are also can change headache frequency. This is one of my favorite sort of ideas about headache. It sort of puts all of headache medicine into one picture, devised by David Rothner. So our kids with episodic recurrent headaches are the ones with migraine, the chronic progressive. Those are the kids that we really need to worry about in daily persistent headaches. And the chronic non-progressive, those are the kids that I know that people struggle with in clinic, the chronic daily headaches. Oh, can I adjust the microphone? No. Sorry, I tried to get headphones and was not able to for this computer. Should I go more slowly?
Yes, that'd be
Okay, so acute headaches could be almost anything. It could be migraine, it could be URI, it could be possible, it could be tumor. And so for those kids, you know, time is on your side to be able to see, is this going to keep getting worse and turn into a chronic progressive headache, or is it an isolated episode? I can try and get close to the computer. So when we're seeing these kids in clinic, we really want to get a good history about what history of headache, frequency, severity, onset, change in headache over time, family history, what other things are going on in their life, in their medical history, what else is going on, do they have anxiety, depression, do they want to play professional football, or are they on screens all the time and have problems with that? It really can be important to figuring out and helping them get better. Your exam, you want to also feel their scalp, their skull, and their neck, in the occipital region, seeing if there's any particular parts that are particularly tender, if there's occipital neuralgia, if they have any signs of dysautonomia or cardiac abnormalities. I do a skin exam, and I found signs of cutting much more often than I find signs of neurogenic sigmoidosis or NF and those types of things. So I try and at least look at forearms and ask about other birthmarks. Then the neuro exam, basically you're looking for asymmetries, differences, things that are abnormal, mental status. And if you can't get a good fundoscopic exam, I do recommend referring them to optometry or ophthalmology because they have a lot better tools than we do, just using the rectophthalmoscope on the wall, and can give you very crisp and objective results using an OCT so they can kind of see if there's any swelling. Sorry, there we go. So these are the official migraine definitions from the International Classification of Headache Criteria. I just put a few of them here. So for migraine without aura. In the kids, these are a little bit different. So in adults, it's a unilateral location. You've had to have at least 5 attacks with 2 of these characteristics. So in kids' headaches, the migraines are often bifrontal or bilateral or bitemporal. Pulsing quality, if you have time, you can get them to draw a picture or give them a list of options. Moderate, severe, oftentimes they're often moderate, severe by the time they come to see you in the clinic. And then either nausea and or vomiting or photophobia and phonophobia. So for the brief things we do initially for migraine are lifestyle modifications, taking away any of overused acute medications. So that's not been as much of a problem here in the Northwest, I think, as it is in some other places, at least according to some of the studies that have been published. I just don't see it quite as often here. Then talking about abortive medications, trying to figure out the best option for each kid, letting them know that they need to take it at the onset of a migraine, but not taking it every day. And then thinking about preventative therapies. And then we would do that if kids are having 4 or more disabling headaches per month. So talking about all that in the next 8 minutes is probably difficult, but you can always email me or you can talk after, have questions afterwards. So Dr. Almatine down in Mary Bridge came up with a SMART mnemonic for lifestyle modifications, which I've always liked and published everywhere, and he's given me the go-ahead to share it with everybody. So sleep, making sure they get regular sleep. You know, six-year-old needs more than 8 hours of sleep. You guys all know that, but sometimes families don't. Make sure they're getting regular meals, eating nutritious foods, not being a vegetarian and having pasta and cheese as their only diets, or making sure they're not withholding nutrition, drinking plenty of fluids. For your average teenager, I usually recommend at least a trial of doing 60 to 80 ounces a day and using of fluids overall to see if that helps. And they can use some of these apps like the Plant Nanny app or other apps to help them remember. And then try, if they are overusing caffeine and using it more than 2 days a week, then doing a trial of coming off the caffeine or tapering off the caffeine. Because if caffeine does have good data that it can cause medication overuse. The things might get worse before they get better. And regular exercise, a relaxation and stress relief, and trigger avoidance. So if you can do all those things, you're doing pretty well. So the AAN, AAP, CNS, migraine, acute migraine treatment guidelines are really somewhat common sense, partly because this is what we know works and what's important, and partly because there's not as much data about there's not a lot of hard, large trials, large randomized control trials in pediatrics. So first trying to figure out, is it a primary headache or secondary headache? Is it migraine or tension type headache or some other type of primary headache, like a primary stabbing headache? Getting a history of the headache symptoms, or if they have aura or not, what kind of disability they're having, let people know that migraine works better, even used earlier, letting people know that the first medication may not be the one they end up on, but it may be a combination treatment, so a few different trials may be necessary. And there is data that using an NSAID like ibuprofen and naproxen with the triptane can be more helpful than either one of those on their own. So I'll try and have kids, if kids don't respond to one or the other as well as they'd like, then I really try and get them to take it together. And I'll try and get them to take it together early on. You should think about anti-nausea medicines. If I'm trying to just treat nausea, I'll use ondansetron. If I'm trying to treat migraine and nausea, I'll think about using prochlorperazine, acomazine, and phenytoin. Talking about helping habits, like we talked about, making an agreement with the family so that, if the family leaves there thinking that you're crazy and don't understand what's going on, then that's not going to work very well. So I try. It's not always, definitely not easy with teenagers, but trying to get their input and buy-in into some lifestyle changes or medications is really important. And then trying to avoid medication overuse, trying to use less than 14 days a month of NSAIDs and definitely less than 9 days a month of triptans. And then, especially in the guidelines, you want to avoid triptans for those with ischemic disease, stroke, or heart attacks, which is not such a major issue in pediatrics. But you also want to use, this is not in the guidelines, but I wouldn't use them for kids with transplant or other issues where vasoconstriction could cause problems for them. The migraine prevention guidelines in the AAN and AAP also somewhat text heavy and lengthy, but again, a lot of them are sort of some of these common sense things, talking about lifestyle, behavior, and how behavioral factors can go into migraine frequency and headache frequency, talking to them about how they can change some of these things. Discuss, and this is where it's tough. I don't know how many of you are aware of the CHAMP study where they we looked at amitriptyline, topiramate, and placebo. And for those who completed the study, all three arms had about a 70% responder rate. So 70% of kids had a 50% reduction in their headache frequency. However, there was no difference between the placebo and the medication groups. So why that was is still not quite clear, but at least people agree that it seems to be at least pill-taking behavior seems to be helpful, and many different treatments will work. So that's one of the take-home messages from that study, and that's where this comes from. Acknowledging the limitations of current evidence. Really, there's only been that one. The CHAMP study is the only large, independently funded randomized control trial for preventive treatment of migraine in kids. It's funded by the NIH. And so seeing how things go, making sure that kids are taking the preventive treatment at least ideally for about 8 weeks, but if they're doing better after 8 or 12 weeks or a couple of months, then thinking about maybe coming off of it. But if you're on 3 different meds for a week each for prevention, that's really not going to work very well. The other thing where there's good data for amitriptyline, the CBT, for migraine prevention for chronic migraine, and that actually did really well with that. The majority of the kids going down to less than 4, from over 15 days a month for migraine to less than 4. So that's one of the stronger pieces of data that we have. The recommendations here for the other medicines are to discuss, because the evidence is less, a little bit shakier. So the evidence for topiramate, propranolol, and some of these other treatments. There are really nice tables review all the data, but I just didn't, for sake of time and place, didn't put those in tonight. But I'm happy to send those to you. And the links to the guidelines are on the referral page. Other major things they talked about were just discussing the teratogenic effects of pyramate and difficult, talking about the fact that if a female is on OCPs, with the tropyramate will decrease the efficacy of those combined oral hormonal contraceptives, especially if you're using tropyramate dose in the higher range. I don't usually go up to time, but very muffled again, sorry. Just counseling about teratogenic effects and tropyramate. And then consider using folic acid for patients who could become pregnant who are taking those medications. But it doesn't end there. So also talking about stopping the preventive medicines once your migraine is established, and screening for mood and anxiety disorders is really important. Even I tell patients that stressed out rats will take their paws out of hot water, or take their tails out of hot water more quickly than non-stressed rats. And so if you've got a kiddo who's got significant depression or anxiety or other mood disorders or stressors, it's going to be really difficult to manage their headaches without managing their anxiety and depression as well. And so it's important to either refer or discuss the management options for those disorders as well. So these are some of the things that I apologize if the sound is still bad. I don't know. Hopefully things you can hear me okay. These are some of a list of things that are options here at Seattle Children's. We have every department has a toolkit, and I check to make sure that all of these things are accessible by some outside computers as well. We have a headache handout that goes through lifestyle factors, talks about some of the supplements that we'll use sometimes, magnesium, B2, that has some data that's not included in the official AAN guidelines. We also have a copy of a 504 plan that we use with a list of options that can be incorporated into the school 504 plan, as well as a lot of blank lines, so you can put your own things in a headache log. There's also a list of apps for stress reduction, biofeedback on the adolescent. And one of the, I think my internet's probably just going in and out, I'm sorry. Pain management resources. So that Dr. Law and Palermo and colleagues have developed a app that's basically like a CBT, cognitive behavioral therapy app for pain for kids with any types of chronic pain, including headaches, that is available for free. You can access it in any app store, or it's also, you can look on the pain. What I've done is just, we have the links, but I can also just Google Seattle Children's pain clinic, and web map is the name of the app. And kids can download it, and it goes a biobehavioral little program that lasts about 5 or 6 weeks, has different components to it that kids can go back and use that again and again if they need to. There's also a list of books that have Dr. Plana have written, and Managing Your Child's Chronic Pain is one that some families find helpful. And the pain team also has a toolkit. And I got a question on the chat about magnesium and supplements. I think I can only see the chat for a few seconds. Is that right, Patty?
Yeah, can you discuss the use of supplements like riboflavin or magnesium in the prevention of headaches?
Yeah, so I was a little disappointed that as well that those weren't really addressed in the guidelines. That's likely because there really isn't a lot of data. There are some small studies looking at B2 in adolescents with migraine. The placebo that they used that had 25 milligrams was as effective as the full dose of 400 milligrams. And magnesium also has some a few small scale studies that I think they just didn't quite meet the criteria for the guidelines, but they are things that I will use mainly, especially if a kid has, what I do try and do is try and match the kid's patient symptoms with an option for therapy, because there's as you know, there's a long list of options for migraine. So that if the kiddo has constipation or some other issues, maybe having a little bit of trouble sleeping, could use magnesium, or I'll sometimes use melatonin if they're really having a lot of trouble sleeping, because if you can get their sleep better, then their headaches will be better. I do recommend using Migraine as long as it won't be a financial burden for the family, because again, I have more confidence that that is as reliable as one can get with supplements instead of picking out a B2 off the rack at Target or Walmart. But it is more expensive. It's like $25 a month. And I certainly have had patients really do well. And if it is a pill-taking behavior rather than an actual medication that's helpful, then perhaps the nutraceuticals may be just as good as some of the others. And there's the data for magnesium and the data for magnesium and B2 is as good as some of the data for some of the other medications that preferred. I got a question about the preferred form. There are a lot of people who are a lot more knowledgeable about that than I am. I take it pretty simply that I try to avoid mag citrate unless I'm really, really trying to treat constipation. So that's difficult because the form for younger kids, it's a little hard because I've only really been able to find powdered magnesium in mag citrate forms. I've heard that there's gummies, but if you're trying to avoid diarrhea, then I would recommend trying to use like a chelated magnesium or a different form of magnesium. Mag oxide is probably in the middle in terms of loose stool, but mag citrate, unless I'm really trying to treat constipation as well, or if we're stuck trying to find a form that's used for younger kids, I'll try to avoid that if I can. And just so this is really sort of just an introduction into headache.
Wait, Doctor. I just want to make sure. What was the supplement that you recommended?
Well, the ones that I'll use often are magnesium or B2, or Migrelief has got B2, magnesium, and feverfew in it. Another one that has some good data is something called Butterbur or Petadolix, but the downside of that is that there's a hepatotoxic moiety in it that people try and take out, but when the American Headache Society no longer recommends using Butterbur because when they've looked at over-the-counter forms of Butterbur, it's got still has the alkaloids in it that can be toxic, so they no longer recommend that anymore, though it is still out there. Then if you could process it correctly, it might be useful, but I've just stopped using it as much. Well, I've really stopped recommending it based on those reasons, but other people still use it. And melatonin. So those are the ones I use most often, would be magnesium, B2, and melatonin, probably, and Migraine. Any other questions that I missed? So I just wanted to go over where things are now at the headache program. We get about 3,000 referrals. We got over 3,000 referrals last year. We saw about 1,600 new patients for headache and neurology. We now have 2 nurse practitioners dedicated to headache, and then so Joyce George is down at the South Clinic in Central Way. Catherine Sletvet is going to be up in North Campus, and Ashley Thibodeau is doing part-time headache and more neuromuscular, and she's going to be on main campus. She is on main campus. We've also have referral guidelines and an algorithm at this website, or you can just Google Seattle Children's Hospital Neurology Headache Referral. And one of the things that's helpful for us is if there's a specific question as well as the billing sheets. And if it just says headache, that's it's helpful to have a little bit more information than that before we see the kids. So, like reviewing patients yesterday, for tomorrow I've got some with 20 pages of records. Tomorrow's a good day, so I've got information about everybody. But sometimes when you just get one line, it's really, and no other records, that can make the visit difficult, and you may not have as much information as you need to really do a good job. That's one thing that's really helpful. I think here's a this is a copy from the website of the algorithm. It's really, I don't expect anyone to read. But there's also another text description of this as well, which may be more helpful with several different links on it, including the links to the guidelines, as well as some other resources. And these are some other resources that we also, I think, are helpful. American Headache Society, Migraine Foundation, Migraine Relief Guide, which is a headache relief guide, which out of Kansas City is really helpful. There's also Migraine Diaries online for apps, which are helpful as well. So I know I've gone over, sorry, Leslie. But I can either answer some questions now or at the end.
If anybody has any questions, I'll give it. I'll just text really quick, and then I'll try to unmute you so you can ask the question. Otherwise, I will. We can transfer it over to Dr. Novotny. Okay, I don't see anybody texting, so thank you very much, Dr. Blume. And we'll be sending out slides as well for Dr. Blume.
All right, so thanks everybody for attending this in the late evening on first or second day of summer. I gave this talk about 6 years ago in Tri-Cities, and so I wanted to sort of, well, what's happened since 6 years, over the last 6 years? And I kind of want to update in terms of how we investigate both first seizures and epilepsy in general here at Seattle Children's and sort of more nationally. As Mark mentioned, our program is still going. We're doing a lot of telehealth and telemedicine. For a lot of reasons, epilepsy is very important disorder that telehealth works very well. But what I wanted to talk about was actually since 2012, 2013, when I last gave this talk, there's been a lot of changes. In 2014, there's actually a complete new definition of what is epilepsy. And in 2017, there's actually a new classification of seizures in epilepsy. It only took 30 or 40 years to get a new classification that was last in 1989 to get the global world to agree on the diagnosis. But as a result of this, there's a lot of great resources that I'll share with you. One is a website called epilepsydiagnosis.org. And it gives some great descriptions of seizures and seizure types, as well as, more importantly, video clips of what do different seizures look like. So it's important resource that for any healthcare providers, patients and families use these as well. And then I'll integrate this into how does our first seizure clinic work at Seattle Children's, which we've been going since about 2011. So epilepsy is the most common, one of the more common neurologic disorders. It really affects 1 in 20 children. And this was from the Institute of Medicine in 2012. We know now that there are 40 different types of epilepsy and epilepsy syndromes. Oftentimes epilepsy is associated with other problems such as brain injury, neurologic and cognitive problems, psychiatric problems are very common. And then there's a condition that happens with patients and children and adults with epilepsy called sudden unexpected death in epilepsy. And in 2017, the CDC looked at a lot of data throughout the US, and there's over 3 million adults with epilepsy, over nearly 500,000 children. And then from the CDC statistics, about over 10,000 children in Washington have epilepsy. And throughout the WWAMI region, it's up to around 27,000. So it's a very common disorder. This is some information on the epidemiology of epilepsy. What we do know now is that there's a highest incidence in the first decade of life. Actually, the neonate is where we first see seizures and early onset epilepsies. And then what we're now seeing as well past the age of 60, the incidence is gradually increasing. We know that a single unprovoked seizure is very common. So 1 in 10 people in their lifetime will actually have a seizure. So it's a very common phenomena. But how that evolves into epilepsy is very different. So this is from the 2014 new clinical definition of epilepsy. And it's a clinical definition that it doesn't necessarily need to use diagnostic studies. So in the past, the typical definition of epilepsy was having 2 unprovoked seizures that occur more than 24 hours apart. So you have to ensure that they're not provoked anything. So certainly in children, febrile convulsions are a provoked seizure and is not epilepsy. But now with new epidemiological data and other data, we know that one single unprovoked seizure with some data that identifies that a person is at higher risk than the general population, which means a greater than 60% risk factor, also has epilepsy. And nowadays we can, based on clinical description and often with neurodiagnostic studies such as the EEG, we can actually diagnose epilepsy syndromes right away. Also, as part of this new definition of epilepsy, they've also identified, well, when does a patient outgrow their epilepsy? And this is what's fortunate in many pediatric patients. There's a lot of forms of epilepsy or epilepsy syndromes that are self-limited, and often children will outgrow their epilepsy. And identifying that type of epilepsy syndrome is important. But we now know there's a specific age for certain of these pediatric epilepsy syndromes that we know expect them to outgrow. But if a person has epilepsy and they're taken off of medication, they're identified to be completely seizure-free after 10 years. And 5 of those years have to be without medication. So this is important in terms of transition of care of pediatric epilepsy patients to the adult, in terms of their vocations and a lot of their lifestyle activities. There's actually not that much different in terms of the classification of seizures in epilepsy. It's basically separating epilepsy into 2 types, what are called focal epilepsy. It used to be called partial or complex partial, or generalized epilepsies are the 2 main types of epilepsy. It's important to make that description and identify that on clinical basis and also based on clinical exam and neurodiagnostic criteria. It's important to separate these because long-term prognosis, what you do in terms of diagnostic workup is important. In 2017, this is the new classification. And I think what's important to recognize, we identify seizure types, but we also identify epilepsy types based on the type of seizures that they have. But they also emphasize and integrated into the classification is the underlying diagnosis. What's the cause of their epilepsy? And is there a structural cause? Genetics is becoming an increasing identified cause of epilepsy in children. And when I was in medical school and in training, 70–80% of epilepsy was felt to be idiopathic or not known. And now a high percentage of those idiopathic are now genetically determined. We also identify, based on the underlying etiology and the epilepsy types, there's a high incidence of certain comorbidities. And they may be intellectual disability, autism, specific learning disability as well. So recognizing that comorbidities are very common in seizures and epilepsy is very important. So these are some of the new things that happened in the 2017 classification. And we spend a lot of time both identifying seizure types, but trying to better define specific epilepsy syndromes and epilepsy types, because that helps guide therapy and give a lot of information on long-term prognosis. But truly, the epilepsy, and this is why telemedicine works so well for epilepsy, because 80% of your diagnosis is based on your history. And it's important, as Heidi said with the headaches, it's history and history and history. You need to get a detailed description of the event. Is there an aura that occurs? What's the duration of the event in as much detail as you can? In the present day and age, with everybody having their smartphones, we get tons of videos of behaviors and events thought to be seizures. And that is extremely useful in terms of helping making a diagnosis. The physical and neurological examination is important and helps supplement what you get from the history. And obviously, family history is important, particularly with the genetic causes of epilepsy that we commonly see. It's important to note from the genetic standpoint, a high percentage of epilepsy and seizures that are genetically determined are often due to what are referred to as de novo mutations, where neither parent often has the gene, and these are new gene defects or pathogenic variants that happen de novo in the child. The next second most important aspect of making a diagnosis are the clinical neurophysiological studies, or EEG, and in many cases we require imaging, but it's not necessary at the initial diagnosis in some situations. As I mentioned, what's important is history, because, and in that website I talked to you about epilepsy diagnosis, there's a lot of imitators of seizures or epilepsy, and that's very age dependent. And certainly in the neonate and infant, apnea, breath holding spells are very common. In the early childhood, 2-year-olds and early childhood, a lot of behavioral and sleep disorders are actually more common or as common as seizures. And then finally, in late childhood, there's a lot of movement disorders that are more common, such as tics or chorea or other disorders. So it's important to recognize that there are many, many other disorders that can be what we often refer to as imitators of epilepsy that are important in your differential. And most of the time, the history is most useful in distinguishing these. So I wanted to get back to what are some of the clinical neurophysiological studies and how do we make a diagnosis with EEG. We know from a lot of extensive studies that a routine EEG, if you have a question when patients with known epilepsy, the diagnostic yield is only about 30%. And the duration of the study is about 30 to 45 minutes. We usually do provocative maneuvers of doing photic stimulation and hyperventilation, and that increases your yield. But we also know if we can record sleep during that routine EEG, it doubles the sensitivity and being able to make a diagnosis of epilepsy as well. So ensuring that if an EEG is done, that sleep is recorded during that time, and that's achieved either by sleep deprivation or doing or minor sleep deprivation to get sleep during the time, or in young toddlers and infants, we do the EEG around their nap time, for example. We also have a lot of other technologies. We can do ambulatory EEG where a patient can go to their home and back in over 24 to 72 hours. Some studies have been done, but not in a lot of detail. This has about an 80% diagnostic yield. And then we also have the capability of doing video EEG monitoring for either in the outpatient setting for several hours or up to days if needed in the inpatient setting from a diagnostic standpoint. It's important to recognize, so what are the more common forms of epilepsy that we see in children and ones that require prompt referral? I think epileptic spasms, we actually use the term epileptic spasm instead of infantile spasms nowadays with the new classification. We have an actually very specific protocol when we hear that as a diagnosis, possible diagnosis. Through the clinic that Mark mentioned, we see these patients within 2 to 3 days. Again, these children are often having very, very frequent seizures, and they have a very specific pattern of behaviors with their seizures clustering usually around sleep, and a very specific EEG pattern referred to as hypsarrhythmia. There's a condition that used to be called benign Rolandic epilepsy, and now it comes under the category of self-limited focal epilepsies of childhood that are often genetically determined, and they have a very specific EEG pattern. And they're typical as a child that has their very first seizure, either after going out on camp or staying over at their grandmother's or friends overnight, and they have a first seizure because they've sleep deprived themselves and they have their first nocturnal seizure overnight. And that's a very common scenario when we see these patients. And second, a third common one we see in children is childhood absence or epilepsy or non-convulsive generalized seizures. And that has a characteristic EEG pattern, and it's often mistaken for inattention. Peak age of onset is around 6 or 7 years of age, and they have very brief 3 to 10-second periods of brief alteration in awareness with some eye blinking or blank stare that can be frequently misinterpreted as something other than seizures, epileptic seizures. This is just the EEG in hypsarrhythmia is very unusual. You never see this in any other condition. This is the typical EEG. What we see in so-called Volandic epilepsy has a very characteristic pattern in a specific region of the brain called the central temporal region. And then this is the classic 3 Hertz spike and wave seizure that we see in an EEG with routine EEG. We know I was involved, and so was Seattle Children's, in a multi-center NIH-sponsored study of looking at childhood absence epilepsy. And we know that a 1-hour EEG with a clinical history compatible with childhood absence epilepsy has about 90% sensitivity of making the diagnosis. So, so the EEG is really an early frontline diagnostic tool when you're really suspicious about childhood absence epilepsy, and has a high diagnostic yield. So there's a lot of questions and data that come up. When do you obtain, what's the timing of the EEG, and what's the type of EEG that you should get? Optimally, you want to obtain an EEG during the event in question. In some children, like children with absence, you often will catch seizures because typically if you take a history, they're having dozens to several seizures a day, and doing a routine EEG has a high yield in actually capturing an event. And actually we know hyperventilation actually is a provocative maneuver that actually will trigger seizures in children with absence epilepsy, and that's why it's routinely done as part of a routine EEG. We also know from a lot of studies that if a child has a seizure, your next highest yield, if you obtain that EEG within 24 to 72 hours from the episode, that will increase your yield quite a bit, particularly if you obtain sleep. And then the third phase, you would obtain a routine awakened sleep EEG. And then finally, we can, as I mentioned, we can do prolonged studies up to 24 to 72 hours in the ambulatory setting or inpatiently to be sure we make a diagnosis in some situations. So we have a very specific seizure algorithm. And again, the history is most important, and your physical exam. If they have a normal exam and you have a good clinical history, we then will often obtain an EEG. And based on that and the clinical history, consider obtaining neuroimaging, and MRI is the imaging modality of choice. We know if we make a diagnosis of childhood absence, there is a recommendation that imaging should not be obtained. So there's no imaging need with childhood absence. Children who have an abnormal exam, we try to coordinate EEG and MRI simultaneously to get that data soon because of the abnormal exam. And sometimes you get a clear clinical history right away that they have had an epileptic seizure. They're either seen in urgent care or ED. EEG should be done as urgently as possible if it can be scheduled. And lab should be guided by the clinical history, often followed by imaging. And then we often get the other seizures, which are the imitators of epilepsy that often require further evaluation. So our first seizure clinic has been at Seattle Children's since 2011. We have a very large referral pattern. We see a lot of patients both at our clinic satellite clinics and some also in some of our outreach clinics in this setting. We expect the referral to be from the PCP. A patient may be seen in ED with a follow-up visit by the primary care provider, and getting that referral both at the times of the ED with information from the primary care provider is extremely important. patient and family, we try to get them to be seen within 5 to 7 days. And that is now integrated with our new acute clinic that Mark had mentioned at the beginning. When we get that information, it's important to relate to the family that to get the history and the physical is really paramount. So if a patient is seen in a primary care provider's office, getting the detailed history, particularly family history, is important, but also have them provide them with either a seizure log or a calendar because of events that are continuing to happen before they are seen. We can certainly prioritize and have them seen sooner. Or also encourage family, if at all possible, to obtain a video of the events of question that can be very helpful in terms of helping with the diagnosis. Finally, we typically try to coordinate an EEG exam, which is more typically guided by the history and the clinical exam in the visit. If the clinical history beforehand, sometimes we'll obtain that study the same day prior to the clinic visit, or coordinated depending on where they live with the clinic visit. So that's our typical referral for our first seizure clinic. We spend a lot of time guiding the metrics for our first seizure clinic to ensure that we're trying to meet our goal of patients being seen in that first 7 days. And these are data since January of 2020. And as you can see, we adjust our clinics so that we have slots available for patients that need to be seen in this first seizure clinic. So these are the number of slots available for patients to be seen in first clinic, and these are the ones that are actually filled. So we actually meet are adjusting our schedule so that we can always see these patients in that required period of time. But once patients are seen in seizure clinic, what's the typical diagnosis we get? So oftentimes we make a diagnosis of seizures, or epileptic seizure, which is often identified as an unspecified convulsion, meaning we don't really have a clear, is it a focal seizure, is it a generalized convulsion? We don't have enough data to specify the exact seizure type. And that's what needs to be followed over time to identify the seizure type, and then potentially, ultimately, the epilepsy syndrome in some cases. But we also get a lot of patients who are seen in first seizure clinic who don't have epilepsy. A lot of them have inattention or transient alteration in awareness and may have more of an attention disorder, or they may have a sleep problem that they're overly sleepy the next day, and that's why they're having transient alteration in awareness. Many of them have simple syncope or collapse. We see a lot of patients referred to first seizure clinic that actually have a movement disorder. They have tics, or they have other things that are not non-epileptic. And again, particularly with absence epilepsy and the Rolandic epilepsy that I mentioned, oftentimes that EEG obtained on the day of that first seizure clinic is diagnostic, and we can specify a specific epilepsy syndrome. But again, we roughly about 2/3 of the time in our referrals, we make a diagnosis of epilepsy or seizures. And sometimes they're complex febrile seizures, but oftentimes they're a form of epilepsy that need to be followed over time and potentially treated. And Justin, I don't have enough time to get into treatment because we only have 30 different medications to consider to try. But we usually don't treat children after their first seizure until they've had a adequate evaluation. So,
Novotny, I'm sorry to interrupt. I had a quick question that we got from Mary Jo Shah. So, how helpful are EEGs done at outside the hospitals? At outside hospitals?
Depends where. And we have a lot of good relationships with some of the hospitals that we can not only get the EEG, but we can actually get the EEG data, because all the EEG now is digital, and they will often transfer the actual EEG data just like they transfer images outside MRIs or CTs, and we can often review that. And so particularly a lot of patients who are our epilepsy program, where we can actually get the actual EEG data and as well as the report. and that adds a lot more to the being useful. Here are some of the references in terms of the new classification, the new seizures. The AAP has a wonderful site referred to as the National Coordinating Center for Epilepsy, and they have very specific recommendations on the diagnosis and management and early diagnosis of infantile spasms or epileptic spasms. And then also that the epilepsydiagnosis.org is a very useful new resource for people to be able to sort of look at the classification, actually look at videos of what different seizures look like. And as I mentioned, there are 40 different types of epilepsy syndromes and different types of seizures. So it's not your typical convulsion or generalized tonic-clonic seizure that people think of when they think about epilepsy. Open to any questions at this point?
I'm going to unmute everybody just in case you have a question and you want to actually ask live. So if you're in a spot where it's kind of loud, please go ahead and just mute yourself. You can mute yourself individually.
Escucho de más.
Dr.
¿Estás viendo?
Son dos tortillas, pero es que son grandes tortillas.
Yeah.
Okay.
All right. I think that was great, Dr. Novotny.
Can people still hear?
Dr. Novotny, I was trying to unmute everybody, but there's too much background noise. So now I am looking through the list so I can unmute Jen and I can unmute some of the people that we're going to start talking. So just give me a sec. Dave, you're unmuted right now. Jen, you're unmuted. I'm trying to figure out how to unmute Aaron.
Actually, Patty, on mine, it doesn't look like Aaron is muted. So this is Jen Muller back again. We wanted you guys to have an opportunity to speak to either Dave or Aaron Williams. Dave is the Senior Director for Regional Clinics, and Aaron Williams is Senior Director for Systems Access and Innovation. I just want to talk to you real quick and give you a quick idea of what is our response to COVID at the regional clinics and what we're doing as far as access. So I think I'm going to pass it on over to Dave first.
Yeah, hi.
Do you guys
Thanks,
have,
Jen.
Dave, I was just saying, if you guys have questions, please go ahead and put it in the chat box, and I will just go ahead and ask Dave, but please feel free to ask questions and we'll try to keep up with them. But that's just so we don't get that background noise to unmute everybody.
Sounds good. So again, yep, my name is Dave Stolte, and I just want to give you an update on the status of our clinics because I think that's variable from healthcare organization to healthcare organization. So right now, all 6 of our regional clinics are open, seeing patients in person as well as telehealth. So we've definitely ramped up our telehealth capacity and ability during COVID, as have most other healthcare organizations. Our 3 large clinics in Bellevue, Everett, and Federal Way are seeing most of their normal list of specialties. And what we're trying to do is be very intentional and careful and safe with our ramp up. So we started with a 30% in-person to 70% telehealth ramp up. Did that for 2 weeks, and during these phases, we monitored our ability to social distance, made sure that we were able to keep the queues down and the line to check in, keep our lobbies empty, and then keep our team spaces safe for our staff. So we went through a 30% ramp up and then 50% for 2 weeks. And right now we're hovering right around 60% in-person visits, and then we'll ramp up to 70% and then 90% in the end of June, early July. And theoretically, we'll go to 100% July 13th. I don't know. I suspect we'll always have a sizable, or at least a measurable percentage of telehealth visits. And and we want to make sure ultimately our families are safe. So we'll keep track and make sure that we're not having any bottlenecks along that care pathway. So some of our clinics have done self-rooming, so there's very little time in the waiting room at all. They check in, and then the patients room themselves. That gets them into a spot that's definitely more isolated than a lobby. We're continuing doing screening at the doors, so temperature checks, all of that is still going on. Limiting the amount of visitors that are coming into the clinics in order to keep our staff and everyone safe. And also still have a fair amount of our non-patient-facing staff that would normally be in a clinic, having them still work from home. So those are sort of the techniques and tactics we're using to keep our families safe. But as of now, our clinics are ready to roll. So and we're scheduling right.
Dave, I have a question. I'm not sure if you'll be able to address it, but any suggestions for how to get parents to video events? Like, parents are often resisted, so I'm assuming that this is like the virtual, the telehealth stuff. I don't know if you have any input on that.
We've put a lot of work into trying to ease that way for our families to do the video visits using Zoom, and we've put the link in the My Chart so that it's part of the normal flow when they would log in and visit My Chart. They would those that have already experienced that they would just have a link for a Zoom visit. So we're trying to, and it's still a work in progress. I would say we're still fine tuning all of that to make it as easy as possible for our families so that they're able to get the visits, and we can still do phone visits for those that simply aren't interested in the video piece.
Thank you.
Yep. Any other questions for me? Okay, I turn it over to Erin.
Did we get Erin? I don't know if we, Erin is somehow, there's not a way for me to, he's like not got a phone associated, or he might be calling internally and I don't know his number to unmute him. There's no microphone next to him, so
yeah. I'm texting him. Different technology.
That I just unmuted.
Yes, can you hear me?
Okay. Yeah.
Yep.
There was a couple 206 numbers I just unmuted, so.
Awesome. Okay, it worked. All right, so I know we're a little bit over time, so I'll make mine quick. I think I can cover this in about a minute and a half, and I'll keep it high level. Just in terms of neuro, our scheduled utilization rate for the month of June was at 77% so far. That's against our 85% target, and comparatively, we had a 40% scheduled utilization rate in April and 67% scheduled utilization in May, so neuro is getting busier. Regarding access issues at one location versus the other, there is a higher request for appointments in our South location with our general neuro providers. I believe we have one MD there. Although we do have a handful of epilepsy providers that go to that location. And also with our neuro clinic, we have providers who have subspecialty clinics within the department, which we know sometimes limits their ability for general patients, but we are working with our providers, our service line leaders, to do everything that we can to expand access. And I have a specific line item from our schedulers at the contact center that wanted me to bring this to this group. The ask is for referring providers to make it easier on the scheduling process. If the providers can tell families to give us 24 to 48 hours for the referral to be processed instead of having them call right away. And also some referring providers tell families to call, we would call them first. However, if you could tell the families to give us a call after 1 or 2 days, we would greatly appreciate that, and it would streamline the patient experience when they're calling us. If you have any access questions that I can answer quickly now, please let me know. If not, Jen will get those questions over to me, and I'll follow up ASAP. Thank you.
All right, anybody have any questions for Erin that they want to put in the chat box? All right. All right, well, thank you everybody for joining us. You all have Jen, Kent, and my information, and so if there's any other follow-up questions that you'd like to ask, please feel free and just send us an email. Just also wanted to note that when we sent out our reminders, we did send out several helpful tools that you can use in your clinics, as well as a link to the neurology referral guidelines and their algorithms. And we also sent a link that you can fill out your evaluations and just submit it. So it's really easy, and we would really appreciate if you could take just a couple minutes and fill that out and give us some feedback. Like we said, it's our first one, and you know, we're gonna, it's a work in progress, but we have 2 more scheduled this summer, so we want to make sure we do everything we can to make sure you're getting the value you want out of them. So thank you.